We have considered the risk factors, the vulnerability of the plaque, how best we can alter the vulnerable plaque into a stable plaque in the previous sections. Now, if the vulnerable plaque is not taken care of and if it ruptures, what will be the consequence? What is the pathogenesis of acute coronary syndromes, which will be the discussion in this particular section. Pathogenesis of acute coronary syndrome. There is a vulnerable plaque, let us say a small fissure develops or it ruptures. The platelets are exposed to the lipid core of the plaque here and the platelets adhere there. The first and foremost step is the adhesion of the platelets. Then activation of the platelets. Platelets become charged, they change the shape, the receptors come out, exteriorization of the receptors occurs, and then the activated platelets aggregate with one another and they will trigger the thrombosis and produce thrombotic occlusion and total occlusion of the vessel. It is not that a plaque which is vulnerable always remains vulnerable throughout in life. The vulnerable plaque, due to the defense factors, will become non-vulnerable, or again the non-vulnerable plaque, due to propensity of the risk factors, will be interchanging between vulnerability and non-vulnerability over a period of time. Remember the three important events. First is the fissuring of the plaque or the rupture with 3 A's: platelet adhesion, platelet activation and platelet aggregation, which are fundamental for the next step called thrombotic occlusion. So, a ruptured plaque triggers platelet adhesion, platelet thrombin microemboli will form, and these emboli are nothing but the aggregates of platelets associated with thrombin material. These microemboli travel through the vessel wall, go into the distal sites and occlude the distal vasculature, and they also trigger inflammation, spasm and endothelial dysfunction in the microcirculation and produce microvascular obstruction. This microembolization and microvascular obstruction increases the cardiac enzymes, and there will be several peaks. Whenever there is an embolism coming up, there will be peaks of CKMB that you can see in the blood. Acute coronary syndrome, the pathogenesis, triggering activities of the patients. Acute risk factors of an arterial pressure surge or vasoconstriction lead to plaque disruption. Acute risk factors of coagulability, increased vasoconstriction leading to complete occlusion by the thrombus. So, a non-vulnerable plaque became vulnerable and produced plaque disruption. There will be some amount of thrombosis which is non-occlusive to start with, and this will be maybe asymptomatic because there is some amount of lumen still there and the circulation is going on, or may lead to unstable angina or non-QA myocardial infarction or non-ST segment elevation myocardial infarction. If the occlusion is complete and there is no patency of the blood vessel, that leads to myocardial infarction or sudden cardiac death. This is an occlusive thrombus. So, a vulnerable plaque, a major plaque disruption can occur without going through these steps of non-occlusive to occlusive. It can straight away go to an occlusive thrombus. So, that is, in some cases a major disruption of the plaque can lead to a major acute coronary event and then acute myocardial infarction, ST segment elevation. In some patients, minor rupture, minor disruptions can go through non-occlusive thrombus or may end up in occlusive thrombus. What types of lesions in the blood vessels in the coronary blood vessels cause myocardial infarction? When we look at several studies, the Ambrose study, Little study, Novayoshi study and in the Giraud study, in all of them you see the brown area is less than 50% stenosis, the blue area is 50 to 70% stenosis, and the yellow area is people with more than 70% stenosis. So, if you look at all the 4 studies, 68% of the acute events occurred in people with less than 50% stenosis, and 18% of the events occurred in people with up to 70% stenosis, and then 14% of the events only are reported in people who had more than 70% occlusion. What does this mean? This says that the degree of stenosis or occlusion to the blood flow is not of importance, because majority of our acute events are occurring in people who have less than 50% or at the most less than 70%. Only a small proportion of the people who have severe stenosis have acute lesions, acute obstructions. So this is to say, it is not the degree of stenosis that determines the acute coronary events, but it is the vulnerability of the plaque that is important. So this has been proved in several studies. So this is very important for us to understand this concept. A quiescent plaque with a lipid core inside. The process is there is plaque formation. If you look at the blood, you see high total cholesterol, high LPA, high small LDL, high LDL. So these are the markers for plaque formation. To say whether there is plaque formation or not, if you look at it, and if you know the patient is a diabetic, is a smoker, we know that there is plaque formation. When there is a vulnerable plaque, there will be tissue factor that leads to clotting cascade, and then there will be inflammation, there will be collagen, that is platelet activation, macrophages are brought into the lumen of the subendothelial space, metalloproteinases are produced. So inflammation, multiple factors, peri-infection, all of them contribute to the vulnerability of the plaque. How do you know that there is inflammation? By C-reactive protein. Multiple factors like adhesion molecules, interleukin 6, tumor necrosis factor alpha, SCD40 ligand, all of them are markers about the inflammation and the infections there. When there is a plaque rupture, macrophages are incited, metalloproteases are seen, MDAs and modified LDL can be seen in the blood. When there is actual thrombosis that is occurring due to rupture, and then the microemboli are carried on to the distal sites, there is thrombosis, there is platelet activation, there is thrombin. You can see in the blood in the form of D-dimer, decrease in the complement, consumption of the complement, fibrinogen is consumed or reduced, and then troponins are increased, CRP is increased, CD40Ls are increased. This is how we can mark whether the plaque is just as a lipid core, whether it is a vulnerable plaque, whether there is a rupture with ongoing thrombosis. This in a way summarizes what we have seen in the previous slide: markers of plaque formation, a stable plaque, LDLC, LPA, homocysteine. Markers of inflammation, vulnerable plaque, hsCRP, soluble intracellular adhesion molecules, interleukin 6, tumor necrosis factor alpha, serum amyloid alpha, also known as SAA, serum CD40 ligand, SCD40. These are the markers of inflammation. Then in the next slide we see the markers of thrombosis and embolism. The markers of plaque rupture, the markers which trigger the rupture or which will tell us that there is a plaque rupture are MDA modified LDL, oxidized LDL, MMP9, matrix metalloprotease 9, CCAM, soluble intracellular adhesion molecules. Markers of thrombosis, D-dimer, complement, neopterin, fibrinogen, troponins, CRP and CD40L. All these tell that there is an ongoing thrombosis. So in a given patient, we can predict reasonably by looking at the various factors in the blood whether there is a lipid plaque, whether the plaque is stable, whether the plaque is vulnerable, whether the plaque has ruptured, whether there are markers of thrombosis.